Good afternoon, ladies and gentlemen, and welcome to this webinar. My name is Bob Freeman and my co-chair is Jo Prance, and it's our pleasure, as I say, to welcome you to this webinar on behalf of MASIC, the charity for women who've suffered birth injury, in particular anal sphincter injuries, but also other problems to the pelvic floor that can produce bladder, bowel control issues, prolapse, and so on. Today's webinar is a series of 5 or 6, and we'll tell you a bit more about the others later. But today's is very much about prevention, with an emphasis on what's called the OASI Care Bundle, a package of measures that's been brought in to try and reduce the incidence. So you'll be hearing an awful lot more about that later. We're very fortunate today to have 4 really excellent speakers, and I'm sure you're going to enjoy all their talks, which incidentally have been pre-recorded, and you'll hear those. And then at the end, there'll be 20 minutes for questions and answers. So please do put in your Q&A on the tab, which you'll hear a bit more about from Jo in a second. But one last thing I would just like to say is a big thank you to our sponsors. That's McGregor Healthcare, Axonics, THD, Coloplast, and Medivent. Without their help and support, we couldn't do these. And I hope it won't be too long before we're having actually face-to-face meetings with their help again. But have a look at their websites. They do an awful lot of products for both the investigation and treatment of this problem. So please do have a look. And once again, many thanks to them. So I'd like to hand over to Jo now, who's going to give you a few points on housekeeping. Jo.
Good afternoon, everyone. Lovely to have you here. So as Bob mentioned, please use the Q&A button to ask any questions you have throughout the webinar. If we don't get around to answering all your questions, there will be the opportunity for you to get those answers after the webinar has ended. Please try and keep the chat button to a minimum unless it's relating to topics that we're talking about. And if you want to gain your 1 CPD point from this webinar, then please fill in the evaluation form at the end. So I'm going to hand back over to Bob, who's going to introduce our first speaker.
Thank you, Jo. It's a real pleasure to introduce our first speaker today, Mr. Abdul Sultan, who's an obstetrician and urogynaecologist from Croydon University Hospital. I think it'd be fair to say that Abdul is an internationally renowned pioneer, if you like, in this area of work. In fact, he was the first, I think, to actually do ultrasound work of women after delivery to look at the anal sphincter, to produce an international classification for 3rd and 4th degree anal sphincter tears, or OASI, and also to highlight that there was a deficiency in training in terms of identifying these tears and being able to repair them accurately and appropriately. And along with Rani Thacker, has set up wonderful education and training courses both at Mayday and around the world, which has been absolutely fantastic. So I'm delighted and very grateful to Abdul for speaking at this webinar today. Now, just before he starts, just a warning for those women who are not healthcare professionals. Towards the end, there are 1 or 2 slides on anal sphincter injuries, and which might for some women be a little bit upsetting. So if that is the case, please do look away at that point, but there will be towards the end of the talk. So without further ado, many thanks indeed, Abdul. We're really looking forward to hearing your talk. Abdul.
Good day, all. I would like to start off by thanking the MASIC committee for this kind invitation. I'm going to talk today about obstetric anal sphincter injuries, who is at risk, are rates increasing, and what are the consequences? So who is at risk? Well, clearly, any woman who undergoes a vaginal delivery is at risk of sustaining an OASI. However, those most at risk are women who are having their first baby. And therefore, I always say that you can have as many babies as you want, provided you don't have the first one. But even if you have a cesarean section for the first baby, you are at the same risk if you have a subsequent vaginal delivery as if you had the first delivery vaginally. Asian ethnicity is also a risk factor, partly because Asians have shorter perineums, and we know that the shorter the perineum, the more likely you are to sustain an OASI. Asians also tend to have smaller babies, but that is not true when they become westernized and adopt a Western lifestyle. They're at risk of getting larger babies, which is a known risk factor. What about shoulder dystocia? Well, shoulder dystocia requires manipulation in order to deliver the baby, and this is why it is so important that when you are performing perineal support, that not only do you have to support the head, but also support the perineum when the shoulders are being delivered, because you can sustain a tear when the shoulders are being delivered. And I'm sure you are going to hear about this later on. So what about occipito-posterior position, where the baby is actually looking forwards? And as you can see from here, the presenting diameter is increased when the baby is in the occipito-posterior position, and therefore more likely to sustain an obstetric anal sphincter injury. The longer the labor, the more likely we are to sustain an obstetric anal sphincter injury. But the main risk factor is instrumental delivery. So as you can see here, once the forceps blades are applied, they occupy at least 12% more space in the pelvis, and thereby increasing the diameter of the fetal head. The vacuum extractor does not occupy any more space, but it is more likely to slip off. And we cannot use a vacuum extractor in every vaginal delivery, and therefore we still need to use the forceps. But what is known is that a mediolateral episiotomy reduces the risk significantly, particularly with forceps deliveries. But it is not just any episiotomy. You got to ensure that the episiotomy is at least 60 degrees away from the midline when the head is being distended. And if you use this Episcissors 60, you can be sure that you are cutting at a 60-degree angle. What about stature? Well, we do know that short stature is a risk factor, but not only a risk factor for OASI on its own, it's also a risk factor if the husband is tall. But you would think that language shouldn't be a problem, but in fact, this case control study has shown that communication is so important that if we do not communicate, if you are not able to communicate effectively with women antenatally and during labor, you are more likely to sustain OASI. So the next question is, are OASI rates actually rising? Well, this is the classification that you're all familiar with. But when I did this study, this was the first study with endoanal ultrasound, in fact, the first study in the world some 30 years ago, looking at the rates in the Homerton between 1989 and 1992, you can see that the rate of third or fourth degree tears was 0.6%. That's about 1 in 200 women having a vaginal delivery. But there was a problem because the classification I showed you previously was not being used in the UK. There was no such thing as a fourth degree tear. I then went on to do studies using endoanal ultrasound before and after childbirth and found that 1/3 of women were having damage to the anal sphincter, which was not documented as a third degree tear. And we have subsequently shown that these injuries were actually missed injuries. And if a proper examination was done, they could have been identified clinically. And hence, I introduced this new classification, which most important of all is it includes the internal sphincter, because a 3C tear, if identified, should be repaired. Otherwise, the woman is more likely to have long-term anal incontinence. So what are actually happening to the rates? Well, here you can see in Glasgow, the rates are rising. In Croydon, you can see the rates are rising for primaps, and in multips, they remain quite the same. If you look at the whole of England, you can see that over this 11-year period, the rate has trebled. So the rates are increasing, but not only in the UK, other countries, for example, Sweden, you can see both an increase in 3rd and 4th degree tears. So why are they rising? Well, clearly, it's not rising because of our obstetric practice. It appears to be rising because we are getting better at detecting these injuries. So what are the consequences of OASI? Well, I'm showing you our data because this is just been published, and it's the largest series in our perineal clinic, which also has tertiary referrals. And these are only first visits between this time period. And you can see that the vast majority of women do not have severe symptoms. If you look at this St. Mark's score, it's less than 2 out of 24. So you can look here at the breakdown of other complications that can occur, and you can see most of them are less than 5%. But this does not really pertain to the woman who actually gets these problems, because for that woman, the rate is not 2% or 6%, it is 100%. And therefore, we need to look at each woman individually. This study has looked at resumption of sexual intercourse, and you can see that you are more likely to resume sexual intercourse earlier if you don't have OASIS. Wound resuturing, secondary sphincter repair, sacral nerve modulation is used in less than 1% of women. But what is so important is that we need to be aware that we cannot compare older studies to newer studies, because the latest studies are looking at repairs that have been done more appropriately and repairing the internal sphincter as well. And if you look at this study from Southampton, you can see the rate of 3A tears is only one case of flatus. With 3B tears, it's more, 7%, 3C 14%, and with 4th degree tears, you can see the rate is 44%, but in fact there was only 2 with fecal incontinence, which makes it 22%. But whatever it is, you can see the greater the degree of tear, the higher the incidence of incontinence. In another study of 177 women using different questionnaires, they found no apparent differences in functional, sexual, or quality of life outcomes across patients with different grades of tear over a period ranging time periods 3 up to 24 months. So far I've been talking about injuries that are recognized and repaired, but what happens to those injuries that are not detected at the time of childbirth? And this is so important when it comes to medical legal issues, where the judge wants to know what would have been the outcome had these injuries been identified and repaired at that time. And as you can see from this study, they have a worse outcome. But the psychological impact on a woman's physical and emotional well-being is unmeasurable. Professor Mike Keegley looked at 81 consecutive women with anal incontinence who were referred to him for a condition and prognosis report. And the social, psychological, and emotional morbidity was really unbelievable. Here you can see ranging from anxiety, difficulty in coping, leakage, going down to anger, and how it affected the woman's well-being. And here you can see on this word description, you can see the words in the biggest print are the ones that are most distressing: embarrassment, loss of dignity, hygiene. These are untold issues that women have to undergo. And you have to remember that fecal incontinence is the most severe type of benign condition that any female has to endure, or any human being has to endure. And therefore, we need to recognize, identify, and avoid this major catastrophe. I'm looking forward to the MASIC first 5-year survey of 325 women after OASI. It is apparent that they have been very significantly affected by the OASI. So when a woman comes to have a baby, it is supposed to be a joyous occasion. She is not expecting to suffer with fecal incontinence. No one has told her that such complications can really occur, and therefore can be absolutely devastating. So how important is a rectal examination? Well, here you can see a rectal examination being done, and you can see the anal sphincter looks intact. But an anal examination does not just mean sticking a finger into the anal canal. Of course, you have to get consent, but more importantly, it is about examining, having good exposure, examining the whole rectum, and moving the finger from side to side. Here you can see what appeared intact previously now shows you that there's a huge grade 3B tear. Most of the muscle is being damaged. So when doctors and midwives write down in the tick box, rectal examination done before and rectal examination done after, is it really a proper rectal examination? Because you can do a rectal examination, but unless you use all the other tips and tricks, such as the pill rolling test, which I described, and the finger lift test to ensure that you actually got the anal sphincter before you do the repair, you have not done a proper rectal examination. And these techniques are all available on our website. But what you need to be aware is that the option of having a cesarean section is there, but it also has its own potential risk, particularly when a cesarean section is performed in the second stage of labor. So in conclusion, we need to ensure that there is more widespread education of mothers antenatally to dispel their fears, but at the same time, make them aware of the potential complications of childbirth so they can make informed decisions. Every woman who delivers vaginally is at risk of sustaining OASIS, and she needs to be aware of that. And every midwife and obstetrician needs to develop competencies in making the diagnosis. If you are not sure, always call for a second person to come and check whether there is some injuries. Because if you miss these injuries, these women have a problem later on in life because the outcome of secondary sphincter repair is not good. When OASI repair is performed, it should be done by a certified obstetricians who are at least under supervision. And lastly, you need to be aware that cesarean section also has its risks, and therefore you need to weigh the pros and cons before making a decision. I would like to finish off by leaving you with this. The way a woman gives birth can affect the whole of the rest of her life. How can that not matter unless the woman herself doesn't matter? Thank you.
That was excellent, and thank you very much indeed, Abdul. And we'll have questions. Please put your questions on the Q&A section, please, for Abdul, and we'll ask those at the end. And now let's hand over to Jo Prance, who's going to introduce our next speaker, Jenny Tan.
So our next speaker is going to be Jenny T, who is a MASIC advocate and also a trustee. She's going to deliver her talk on a woman's perspective on instrumental delivery, birth injury, and the OASI care bundle. And I'll have a brief Q&A with Jenny after her presentation.
Hi, I'm Jenny. I'm a MASIC trustee and a MASIC ambassador. I'm passionate about raising awareness about birth injuries and shattering the social taboo of fecal incontinence. By speaking about my own experience today, I hope to encourage other women that might be suffering in silence to come forward and seek professional help. My daughter was born 11 years ago. It was a very traumatic birth. I was unlucky, poor care in labour, a missed tear, and then an effort to get the care and treatment I needed afterwards. I'm still suffering the after effects of the instrumental delivery. My injury wasn't the worst type, but it has affected my career, my personality, my health, and my personal life. I hadn't wanted a natural birth. However, I was denied by my midwife on the grounds that I was fit and healthy. My reason for requesting elective was that I'm petite, and as an older first-time mum at 37, I was statistically more likely to need an instrumental birth, which I was desperate to avoid. I was concerned about having bladder weakness afterwards, having an episiotomy, or needing stitches. Even though I had done some research, I was completely ignorant about anal sphincter damage. My midwife told me that severe tears are actually very rare. She told me if I did tear, I would have a few stitches, but would be fine afterwards. So even though I didn't really want a natural birth, I was reluctantly prepared to give it a try. Should I get into difficulty, my preference was to be taken straight to theatre for an emergency section. In labour in hospital, everything progressed normally until I reached the second stage. I pushed for 2 hours, but my baby was back to back and stuck. The labour slowed. The midwife shift changed. I was moved to another ward and put in a room on my own and told to wait for the doctor to see me and administer some drugs to increase the contractions. Hours passed. Midwives would come in, look at my notes and go away again and not tell me anything. My husband went home. I was alone and exhausted, in extreme pain, and by this stage had had an awful lot of gas and air. Finally, someone noticed the baby was distressed, and all of a sudden the atmosphere changed. People started fussing and the registrar appeared. I would need an instrumental delivery, so I had to be cut. Ventouse was unsuccessful, so I then was prepped for a trial of forceps. I was now an emergency and they had to act fast. The registrar told me it was too late to have a section and that I had to go to theatre for forceps delivery. A midwife hurriedly listed the potential risks. She mentioned damage to perineum, but I assumed it would mean a few stitches. I had no idea that damage could mean tearing right through muscle and skin and nerves. A consent form was given to me and I was pressured to sign it. My head was in a fog from all the gas and air, and there's no thought for my own well-being, just to get the baby out. Nobody had looked at my birth plan. In theatre, 2 people had to hold me to stop me sliding down the bed while the registrar pulled with the forceps. Afterwards, I was told I had a 2nd-degree tear with an episiotomy, and I got a few stitches. Despite the long stage, episiotomy, failed ventouse and forceps, I was not given a rectal examination. Once the epidural wore off a few hours later, I remember being in the most excruciating pain. Aftercare advice was keep the stitches clean and dry, and that was it. I started to have problems as soon as I got home from hospital. I had trouble controlling my bladder and bowels, which didn't improve. So after 1 month, I saw my GP, who told me it was normal. Nevertheless, I was still in a lot of pain and insisted on being referred to see a consultant. At that consultant appointment, 3 months after the birth, I found out the stitches were infected and that I had actually suffered a 3C tear and a significant nerve injury. It was a big shock. Because of the length of time since the birth and presence of a nerve injury, the consultant did not feel that surgical repair was appropriate. I went away with a tender machine and a long list of exercises to do. When I returned for assessment 6 weeks later, there had been no improvement. I was devastated and so angry about it all. Angry that my injury was missed, angry it had happened to me, angry that my GP, who said it was normal and nothing to worry about, didn't take it seriously, but most of all, angry that I was probably going to be doubly incontinent for life. And there wasn't anyone I could talk to. There were no hospital support groups, and back then there weren't any Facebook groups. I felt very alone and isolated. I couldn't find any information about long-term recovery from severe tears, and there was very little about bowel incontinence following childbirth, so I thought I was the only person that this had happened to. I soon became depressed and started to have flashbacks to the moment in hospital when it all started going wrong. I had trouble sleeping and felt like I had failed as a wife and mother. Some days I would cry all day. I hated being me. I hated being doubly incontinent. I felt resentment towards the mums who I met at mother and baby groups who'd had easy births or sections. I wished misfortune would happen to someone else just so that I would have somebody else to share in my misery. My personality changed. My husband said to me one day, "You never laugh anymore. You used to be such a fun person." So what's it like living with the consequences of a severe tear? The early days were horrible, I must say. There was depression, there was times when the incontinence would take me by surprise. 11 years on, I still have problems. Being incontinent dominates my daily life. I have very little control of bladder and bowels and no control of wind. The nerves never did recover properly, so as well as some reduced control, I have altered sensation, which means either I can feel too much or not enough, which often results in a frantic dash to the toilet. I have prolapses, which are uncomfortable and need to be held in place with a pessary. Part of my routine is a morning rectal washout, which can take time and be a bit messy. I'm mindful of what I eat, as some foods can make control a little harder, especially the next day. Stress and anxiety are also big triggers. I can take Imodium if things are particularly bad. Whenever I leave the house, I make a mental map of where all the toilets are and allow extra journey time for emergency toilet trips. I have an emergency card in my wallet for situations when I'm out and need immediate access to a toilet. I have a radar key and an app on my phone which tells me where the toilets are in the area. Sometimes I have spare clothes with me and there's an emergency urinal in the car. Pretty much everything I do requires planning in advance. I had to give up full-time work as I found commuting just too hard. But in those pre-pandemic days, I was lucky enough to find a part-time job working from home. Obviously, COVID has changed everything. But for me, the closing of many public toilets was a real obstacle and did prevent me from going places. And a severe tear doesn't just affect the woman, it's affected my husband too. He felt pushed aside when I was at my most unhappy and depressed. The damage has wrecked our sex life and we both miss that bond and closeness we once shared. And it's been one of the harder things to come to terms with. Had things been different, I'd have liked to have more children, but I was not prepared for a pregnancy and potentially another traumatic birth to make the incontinence worse. My daughter is a very lonely girl. As a tot, she would ask where her baby sister was. It took a long time to accept the fact I wasn't going to have another baby. I should have enjoyed those early years with her, and yet I was miserable and distant. I do wonder now if my behaviour has affected her in ways that I don't yet know about. Problem like mine is time-consuming, tiring, and expensive. On giving up my full-time job, my family lost an income. Pads, pessaries, irrigation kits, it's not cheap. We had to build an extension on a house, so we've got a second toilet now. And over the years, I've pursued as many treatments as I could: intensive physiotherapy, nerve stimulation, bladder retraining, counselling, and biofeedback. Over 40 appointments, including 2 operations. I successfully took legal action against the NHS Trust. My injury has cost the NHS dear too. How would the care bundle have made a difference had it been available to me? Firstly, my choices regarding birth method and attitude towards instrumental delivery and the risks would have been discussed in detail in the antenatal period at midwife appointments and taken into consideration. Any necessary consent would then have been documented in my pregnancy notes. My choices may then have meant that instead of being left to labour for hours, I would have been taken to theatre much sooner. I also hadn't wanted to have been cut, but had it have been done when it wasn't an emergency situation, would more care have been taken so that I didn't tear further when the forceps were used? When my daughter was finally delivered, absolutely no care was taken of my perineum. The registrar had to pull really hard to get the baby out. And then lastly, the rectal examination should have picked up the severity of the tear, repaired in theatre. And for me, this is the important part. Appropriate care would have then been put in place for me straight away, instead of having to find my own way in terms of treatment months later. And then I wouldn't have felt so isolated and alone. Surprisingly to me, there are critics of the care bundle who say it was expensive, has not reduced the incidence of tears enough, that rectal examination is unnecessary and too intrusive, and that divulging information about risks and tearing is scaremongering. I totally understand that some women, for example, survivors of abuse, may find a rectal exam too upsetting. But if the reasoning behind the examination is carefully explained before the birth, as the care bundle sets out, and not in an emergency situation, then hopefully even abuse survivors will see how necessary it is. Opponents also say that further antenatal appointments would be too costly, and time consuming to implement, and would frighten non-risk women into demanding a section birth. But by hiding the truth about damage can increase the fear around childbirth too. I think it's patronising to withhold information that could potentially have a long-lasting impact on a woman's health. Women do have the right to know. Discussion of emergency procedures and potential risks with the mother and her partner need not be alarmist. Any questions can be answered, and the midwife can ensure at this stage that the patient has understood. My 3rd-degree tear has been life-changing. If you can spare just one woman a lifetime of incontinence and other problems, and the care bundle has shown it can prevent tearing, then you should be doing everything in your power to reduce these type of injuries. Thanks for listening.
Thank you very much, Jenny. I think that was a really powerful story that you shared today and highlighted all aspects of what happens when you sustain a birth injury. So now I'm going to have a Q&A with Jenny. So welcome back, Jenny.
Thank you.
And I think you've really highlighted how important antenatal counselling is prior to giving birth. So in terms of information surrounding the use of forceps and ventouse, what do you think women should be told?
Well, I do think there does seem to be plenty of information these days, particularly on the NHS website, about situations when instruments might be used. But there's nothing really about the sort of injuries and what recovery is going to be like. I think you need to be honest about what sort of injuries you get, and just telling women the recovery will be longer and it will be harder, and give them reassurance really that in the end it will be all right.
And then touching on that, because this is another contentious issue, how much information should women be educated prior to birth about the potential risks without scaring them? This is quite a key debate now.
It's a tricky one because I like to know everything. I'm that sort of person. I realise some people are a bit frightened by it and would be put off. But knowledge is power, really. And the more I know about something, the less frightened I am.
And I think you've also touched on quite a good factor there with, you know, if we're quite inquisitive people by nature, we probably go and seek that sort of information if it's readily available. But the other side is, how can you prevent women from being overloaded with information? So it's making it clear for them to pick out the bits that are relevant to them as well. How do you think we can do that without giving them too much overload?
If it's a topic that's spoken about a lot, it does dispel a lot of the shame and embarrassment about it. It's unusual to tear, but it's not scary, really. I don't think. I knew nothing about it and I was unprepared for it, so I was frightened by what my future was going to be. But if I knew that, like I said just now, that it's not that bad, well, the injury was that bad, but there is help available. There is support available now.
And I agree.
It's comforting that there's help.
And I think that's really key that you've hit that note on the head, that there are organisations like MASIC that can help and support women now. And what would you like to see changed with regards to follow-up if you've sustained an OASI? What would you like to see? What would be the ideal scenario?
That if you have a tear identified at birth and it's been repaired, that you're already in the system of support. There should be some appointments already made for you. You don't have to go and see your GP, get referred and go through all of that rigmarole. It's there. You know that in 2 weeks' time you're going to an important appointment and you're going to be checked over. Also, if you need counselling as well, there's a long wait for counselling and mental health support. I think of all the treatments I pursued, the longest wait was actually for trauma counselling. I had to wait probably about 8 months to see somebody. And if you at the bottom of your self-esteem, an 8 months wait to talk to somebody about it, it can be too much for some people.
And I think you've touched on a really important point here, that the psychological aspect of living with this condition is very underestimated, and particularly when women like yourself and myself are presented with problems and we're trying to get help. So yeah, well, we're going to come back to more questions at the end of the webinar, and I'm sure you'll have some more to answer at that point. But I'm going to hand back now to Bob, who's going to introduce our next speaker. So back to you, Bob.
Thank you, Jo, and thank you, Jenny. That was an amazing presentation, and it's sadly one that we, as urogynecologists, colorectal surgeons, hear much too often. And maybe that's something that other healthcare professionals don't hear, and that's why we're so keen about trying to prevent these problems. And I hope those who are listening will understand that even protecting one woman from what Jenny's just described is so important. So the OASI Care Bundle is one way of doing that, and I'm delighted to now introduce Posy Bidwell, who's a midwife and researcher. She's a researcher in qualitative research and has been very much involved in the OASI Care Bundle from the start, and we've worked together very closely. And she's an outstanding clinician and also researcher, and she's done some qualitative work asking both the midwives, obstetricians, and the women themselves what they've thought about the OASI Care Bundle. And so I'd like to hand over now to Jenny to present. Thank you. Sorry, to Posy.
Today, I'd like to present to you information about what women, midwives, and obstetricians think about the OASI Care Bundle. This work was conducted as part of what was originally called the OASI Care Bundle Quality Improvement Project and is now known as OASI 1. This is to distinguish it from the follow-on activities which are now taking place, known as OASI 2, which Magda will present to you later. The OASI Care Bundle is a truly multidisciplinary effort with the common aim of reducing birth trauma. The OASI Care Bundle is the result of a collaboration between the Royal College of Midwives, the Royal College of Obstetricians and Gynaecologists, Croydon Health Services, and the London School of Hygiene and Tropical Medicine. Why did we do it? An OASI stands for an Obstetric Anal Sphincter Injury. OASI is the collective term for 3rd and 4th degree perineal tears, which are severe complications of vaginal birth. Within the NHS, reported OASI rates tripled among first-time mothers from 1.9% in 2000 to 5.9% in 2012. There are known risk factors for OASI, and these include first baby, South Asian ethnicity, birth weight greater than 4 kilos, a prolonged second stage, and an instrumental birth. However, for many women, there is no clear reason why they sustain these injuries. Identified contributing factors include lack of training, lack of awareness, and variation with intrapartum practice, particularly with regard to a hands-poised or hands-off approach to the perineum. It is really important that efforts are made to reduce these injuries, as they can severely impact a woman's quality of life. In light of the rising trends in OASI rates in England, a team of national experts met to discuss strategies to reverse this trend. There was unanimous agreement that there was potential for a care bundle of evidence-based actions to be developed. Care bundles combine elements of good practice into one cohesive package that, when implemented, improve the reliability and quality of care and ultimately improve outcomes. In order to understand what elements should comprise the care bundle, a review of intrapartum interventions to reduce severe perineal tears was conducted. The results of the review and recommendations from pre-existing UK guidelines were presented to an expert group comprising of clinical and methodological experts. This led to a structured discussion about the clinical practicalities of each individual care bundle element. The 4 elements finally included into the care bundle were: Element 1, women to be given information during the antenatal period about perineal trauma and how to minimize their risk of sustaining an OASI. Element 2, documented use of manual perineal protection for all vaginal births unless the woman's chosen birth position does not allow for it. For example, water births. Element 3, when clinically indicated, a mediolateral episiotomy should be performed at 60-degree angle to the midline at crowning. Element 4, following birth, the perineum should be examined and any tears graded in accordance to RCOG guidelines. The examination should include a per rectum check, even if the perineum appears intact. Good communication between clinicians and women is essential for all 4 elements. What did OASI 1 involve? Implementation of the OASI Care Bundle was supported with a skills development module and campaign materials. The Care Bundle was introduced to 16 units across England, Scotland and Wales in a phased rollout from January 2017 to March 2018. Local implementation was facilitated by local midwifery and obstetric champions at each unit. Sustained leadership and support was provided by the professional organisations and the project team. The project collected data for 18 months in order to assess OASI rates pre and post-intervention. In addition to clinical outcomes such as OASI rates, caesarean section rates, and episiotomy rates, we also evaluated the implementation outcomes. This was to understand what women, midwives, and obstetricians thought about the Care Bundle, and this is the focus of my presentation today. We evaluated 4 implementation factors, namely acceptability, feasibility, sustainability, and coverage. These 4 factors relate to acceptability. This is the satisfaction with the intervention. So that relates to whether or not the clinicians, as service providers, liked using the Care Bundle, and whether or not women, as service users, liked receiving the Care Bundle as part of their care. Feasibility. This is an understanding of the practicalities of the intervention. It thereby provides an assessment into the extent to which the intervention can be widely used. Sustainability. This is the extent to which the intervention can be maintained. Coverage. This refers to the number of women who are able to receive the Care Bundle as part of their care. It is therefore a reflection of the number of clinicians who have been trained. In order to measure the 4 factors, we collected qualitative data as well as some basic clinical data. We had 4 sources of data: the clinical champions at each site, the clinicians working at each site, so that was the midwives and obstetricians who were working at participating units, women who received the Care Bundle as part of their care, and monitoring data that was used throughout the implementation period. So what did the clinicians think about the Care Bundle? We identified 4 themes, each with positive and negative components. Theme 1 was around the Care Bundle and how it was introduced to the unit. Positive aspects of this, clinicians talked about having well-advertised launches of the Care Bundle and how this really got activities up to a good start. Clinicians also spoke about the enthusiastic nature that some of the champions had towards training within their units. In terms of the negative aspects, some clinicians felt that the wider maternity team on the shop floor had not been consulted about the unit's involvement with the OASI project and the changes that this would bring. This perceived lack of consultation created some reservations about the intervention. Here's a quote about one of the champions in the unit. So one clinician said and this is one of the OASI champions, she was like a hound. If you weren't trained and you were on her list, she would hunt you down. Theme 2 was around opportunities to use the OASI Care Bundle. Positive aspects here were that the Care Bundle promoted multidisciplinary working, with midwives helping obstetricians with elements of the Care Bundle. Negative aspects. For midwives, many felt that as they work with students, they themselves did not have an opportunity to use the Care Bundle, and this meant they did not feel comfortable or confident using it. The overwhelming theme here, however, was an acknowledgement that change takes time. Many felt they had to unlearn old techniques and get used to new ones. Here's a quote about that multidisciplinary working. So one of the obstetricians said, "You'd have a midwife supporting the perineal body while you did your instrumental delivery." Theme 3 was around receptiveness to change. Positive aspects here were around a recognition that the care bundle was providing a standardised approach to preventing OASI. Negative aspects were, though, that some clinicians felt comfortable with their current practice and didn't feel that they needed to change. Some also felt that the care bundle was taking away their autonomy. As one clinician said, "I know that there's evidence that it reduces severe perineal trauma, but I'm not sure that the evidence is that it reduces the trauma for my particular practice." Theme 4 was around perceptions of what women want. Positive aspects here were around seeing the positive impact of providing women with information in order to help them make informed choices about their birth. Conversely, some clinicians felt that women should be protected from information about perineal trauma, because this is too scary. This clinician, though, was someone who recognised the importance of providing women with information, because this clinician said, some people feel really angry that actually they have no idea that these sorts of things could happen. This project can only really be a good thing in terms of educating women. So what did the women themselves think about the care bundle? During analysis of our interviews, we identified 3 themes. The first was memories of touch, and this related to whether women remembered feeling their midwife's hands on their perineum. For those who recalled it, this was a positive and supportive memory. As one woman said, "I could feel her taking some pressure off me. I felt it was helping. It wasn't painful or uncomfortable." The second theme was around the midwife being a supportive guide. This theme really focused on good communication and being able to establish a good relationship. The majority of women reported that their midwife had communicated clearly with them to enable a slow and controlled birth. This theme also captured women's memories of the post-birth vaginal and rectal examination in order to diagnose any tears. Women talked about being given information from their midwife about the reason for this examination and the risks of not having it. As this woman said, the midwife had explained everything that she was going to do. She was talking me through. I couldn't believe I didn't need any stitches. The final theme was around the need for more education, both in the antenatal period about perineal tears and in the postnatal period about what to expect when women were recovering. As this woman said, just understand why the tearing happens. No one really tells you whether anything goes back to normal. You just have to kind of wait and see. As mentioned in the previous slide about clinicians' perspectives, one of the themes that we identified was around perceptions of what women want. So we put these findings together with what the women were actually saying in order to understand what the women themselves actually wanted. As highlighted, clinicians sometimes projected their personal feelings into how they felt about the care that they were providing. For instance, there was mention that clinicians didn't like doing the colorectal examinations. However, the women themselves reported that they would much rather be checked in order to ensure a correct diagnosis. Some clinicians felt that information about perineal tears is too scary for women and that they should be protected from receiving this information. Women themselves, however, repeatedly said that they needed more information and that knowledge was empowering. Good communication was recognised by both clinicians and women as being really important. Effective communication encompasses providing clear information and also listening. Accurate and complete communication between women, their families, and healthcare professionals allows for shared decision-making. Our results were extremely encouraging and provided greater insight. We found that the care bundle was acceptable to women, and we were able to understand more about why clinicians may be unwilling to use elements of the care bundle. All this information has fed into the development of OASI 2, a follow-on study to roll out the care bundle to more units. We identified an urgent need to ensure that women are fully informed about the risks of perineal trauma and how to reduce incidence, whilst taking into account individual needs, expectations, and circumstances. We also highlighted the importance of women's stories, and we produced 3 animated videos with women recounting their experience of an OASI. These videos are available on the RCOG website, and they're now also available on the new MASIC website. Just to briefly let you know that during the overwhelming need for information about perineal tears, we developed an online perineal tears hub. This provides women with information about perineal tears, how to minimize risk, what to expect during recovery, pelvic floor exercises, and where to access more support. Thank you very much. And just to say a really big thank you to all the women and clinicians who took part in the project.
Thank you so much, Posy. That is exceptional work, and I know we'll come to discuss this in the question and answers later, but thank you very much indeed. It's my pleasure to introduce the next speaker, who's also going to talk about the OASI Care Bundle. That's Magda Jurcek, who is a health researcher working with the Royal College of Obstetricians and Gynaecologists, and she is involved with implementation research. So it's all very well to do research projects, but you must implement the findings into clinical practice, which can in some cases be very difficult. And Magda is going to tell us about how that's happened, in particular the OASI 2, the next implementation study following on from OASI 1. So over to Magda. Thank you.
Hi everyone, my name is Magda Jurcek, and I'll be talking a bit about the implementation of the OASI Care Bundle. I'm a research fellow on the OASI 2 study, which is a follow-on study from the preceding OASI 1 project. My main role for the last year or so has been to write the protocol for OASI 2 and to help plan how we will support implementation of the Care Bundle in more units. The results and lessons learned from OASI 1 were really infused throughout the design of OASI 2, and so that's what I'll talk to you about today. So here we have an overview of the 4 components of the Care Bundle. The first component focuses on raising awareness of OASI and ensuring that pregnant women are able to make informed decisions when creating their birth plan. This is also an opportunity to discuss the remaining 3 components of the Care Bundle so that women know what to expect. The second component is manual perineal protection, and this involves the midwife or obstetrician using their hands to support the perineum during the crowning stage. Third component focuses on episiotomy, and it specifies that if an episiotomy is indicated, it should be done at a 60-degree angle at crowning. Finally, the fourth component is focused on improved detection of tears. We know that if a woman has sustained a severe perineal tear, a successful recovery depends in part on early detection. So that's why the Care Bundle recommends a systematic examination of the vagina and back passage after all vaginal births, including when the perineum seems to be intact. And so it's important to note that components 2 through 4 must only be done with the woman's explicit consent. And that's why component 1 is very important. So the first time that the OASI Care Bundle was trialed was in the OASI 1 project, as we've learned about earlier in this webinar. And this was a project that was a collaboration between the RCOG, the RCM, the London School of Hygiene and Tropical Medicine, King's College, and it was funded by the Health Foundation. So in this project, the Care Bundle was introduced to 16 units, and the project sought to answer 2 key questions. Firstly, is the Care Bundle effective in reducing rates of OASI? And secondly, can it be implemented? So to answer these questions, the following outcomes were identified and measured. To determine clinical effectiveness, OASI rates, cesarean birth rates, and episiotomy rates were monitored and compared prior to implementation with after implementation of the Care Bundle. And then to evaluate implementation, whether or not the Care Bundle can be implemented, both clinicians and women's perceptions of the Care Bundle's acceptability, its feasibility, and its sustainability were assessed primarily through qualitative methods, so interviews and focus groups. So to answer the first question, is it effective? The evaluation of clinical outcomes did find that women's risk of OASI decreased by 20% after implementation of the care bundle compared to before implementation of the care bundle. This was also associated with no impact on episiotomy or cesarean birth rates. So in short, yes, the OASI 1 project did show that OASI care bundle is indeed clinically effective. Second question was, can it be implemented? The answer to this is dependent on how clinicians feel about using the care bundle and how women feel about receiving the care bundle. And so this was discussed earlier in the webinar, but there is yet another factor that needs to be taken into account, which is more focused on the practicalities of implementation. So in OASI 1, implementation was highly supported by the OASI 1 project team, and this involved experts from the RCOG and RCM. In addition to the team, each participating unit also had 2 champions, 1 midwife and 1 obstetrician. And these individuals were responsible for rolling out the care bundle, coordinating training locally, keeping people engaged. And so a process evaluation was conducted in OASI 1 to identify the key barriers and enablers to implementation from the perspective of these champions. To answer the question simply, OASI 1 did find that the OASI care bundle can be implemented. But let's dig into these barriers and enablers a bit more. So on the barrier side, we found that clinicians felt that the care bundle sometimes challenged their professional autonomy. This is particularly true for clinicians who were used to practicing a certain way for a long time. On the enabler side, we found that the care bundle promoted increased cohesion between midwives and obstetricians, which everyone thought was very positive. This next set of factors are related. So on the barrier side, we have clinicians' preconceived notions of what women want, beliefs that women will be overly frightened by learning about the OASI care bundle or about OASI in the antenatal period, or that women, for example, might not accept a post-birth examination. However, this was often countered by clinicians finding that women sometimes proactively asked for the care bundle. And so this very much challenged these preconceived notions of what they thought women wanted. The next set of factors is also related and relates to what clinicians observe in their particular units. So seeing negative outcomes such as any instances of tears, whether they're labial or severe, non-severe, are often discouraging in the absence of any definitive data on the care bundle and whether or not it's effective. And so it's very easy to associate any negative occurrences with the introduction of the care bundle. On the other hand, seeing positive outcomes such as a decrease in tears from month to month is very encouraging. So these balance each other out. Another barrier that was identified was a lack of skills, and this is also coupled with limited opportunities to learn or to train within the unit, particularly in busy units. So episiotomy in particular has been identified as a skill that midwives are much less comfortable with performing. And so also the particular technique for applying manual perineal protection also requires some practice, which again is not always easy to arrange in a very busy unit. On that note, champions did identify that having organizational support from senior leadership, such as heads of midwifery and clinical directors, is helpful in getting other staff to engage, and also helpful on a more practical level when organizing trainings and seeking assistance from others to run sessions. So again, this process evaluation was really key to planning how the team would support implementation in OASI 2. We really tried to capitalize on these enablers while addressing or minimizing the barriers. So what were the lessons learned? One of the lessons we learned as a result of OASI 1 was to expect and be prepared for debate. And there was quite a bit of debate surrounding the care bundle, particularly why certain practices were included and others weren't. There were also some misconceptions regarding the individual components themselves. So the OASI 1 team really prioritized addressing the commentary through updating FAQs on the project website, responding to email messages, and even responding to a critical review that was published at the end of last year. Healthy debate can actually be really useful as it may shed light on something important that wasn't considered. The second lesson is very much related. Through engagement with the public, we found ways to refine the summary description of the components to better address concerns of both clinicians and women. Although the 4 components of the care bundle have remained consistent, the language has been modified to address more common concerns clearly and succinctly, and to avoid getting stuck on these misconceptions early on. Throughout OASI 1, the team met with and sought advice from an independent advisory group, which included representatives from MASIC, as well as clinical experts and women who have had a severe perineal tear. This group has been really central to solving challenges that cropped up in the study from a broader perspective than that of the project team. It has really kept the best interests of women at the forefront of the study, and we have continued working with an independent advisory group in OASI 2. Likewise, OASI has highlighted how important it is for the care bundle to have backing from both the RCOG and RCM. Team working between midwives and obstetricians is highly promoted in the implementation process, and the strong partnership between the RCOG and RCM models just this. And finally, it was recognized that care bundle champions require some protected time to successfully fulfill their role as champion of the OASI care bundle. This is a tough role and requires dedication, follow-up, and coordination of training. This has been built into one of the study arms of OASI 2. And finally, the biggest lesson that was learned was that change takes time, and it's important to take stock of what works, what doesn't along the way, and to try again and not to give up. For many clinicians, the introduction of the care bundle can be a bit jarring and it breaks long-established habits, so it's important to be patient and allow time for the training to really sink in. Now, to switch gears onto the OASI 2 study. So as I said before, OASI 2 is a follow-on study from OASI 1. OASI 1 answered the questions, does the care bundle work and can it be implemented? Now, OASI 2 seeks to understand how to sustainably support its national scale-up. In OASI 1, implementation involved heavy support from the project team, the RCOG, and the RCM. Now in OASI 2, the project team is taking a bit of a step back to assess how the RCOG and the RCM can continue to support widespread implementation, but in a less hands-on way that is more sustainable over the long term. So in OASI 2, there are 3 arms of 10 maternity units each. The sustainability arm is made up of units that participated in OASI 1, and these units will continue to support care bundle use in their setting, while also providing peer support to a new unit. Then there's the lean implementation group, which won't receive any continuous external support. Local champions are elected to lead local implementation as they were in OASI 1, though this time they're referred to as OASI Quality Improvement Leads, or QI leads. All units across the 3 arms will receive an implementation toolkit of resources to support their implementation. This includes a clinical manual that explains how the 4 components of the care bundle should be applied. There's also an implementation guidebook, which identifies 6 strategies that all implementation leads should be using to facilitate care bundle implementation. And there's also an e-learning package that has been developed to support staff training. OASI 2 methods. So how will we evaluate the OASI 2 study? So we will evaluate clinical outcomes similarly to OASI 1, though this time around there will be a renewed attempt to collect woman-level application of the OASI care bundle. So we will be asking clinicians in participating units to note whether or not the full OASI care bundle was used for each vaginal birth. There will also be a series of surveys. We will survey women 2 weeks after birth to see if and how the care bundle impacted their birth experience. And we will survey clinicians at 2 points in the study, at the beginning and at the end, to understand their level of adoption of the care bundle using a validated questionnaire. And towards the end, we will conduct focus groups with OASI QI leads to understand how they felt about their role of facilitating implementation and whether the QI lead role can be replicated in other units, in their opinion, of course. And so if you would like to do a bit of further reading, you can read about the lessons learned coming out of OASI 1 in a piece published in the International Urogynecology Journal. This was part of the themed edition on obstetric trauma. And you can also read the full protocol for the OASI 2 study in Implementation Science, which was published just last month. So in conclusion, OASI 2 represents a shift in thinking from whether the OASI care bundle can reduce OASI rates when implemented with strong support and leadership, to whether it can be implemented with moderate or limited implementation support and still achieve a significant clinical impact. This is a bit more relevant to the typical publicly funded maternity unit and what it needs to successfully implement quality improvement initiatives. We intend to summarize findings that come out of OASI 2 in an OASI Care Bundle implementation blueprint in order to inform scale up of the Care Bundle nationally and perhaps beyond the UK. So thank you everyone very much for listening, and I hope you've enjoyed this presentation.
Well, thank you very much indeed, Magda, and thanks to all the speakers. I'd like to hand over to Jo now, who's going to introduce the question and answer session roundtable. And please keep firing in your questions. Jo.
Okay, so I just want to welcome back now and thank them for their excellent presentations, Abdul, Jenny, Posy, and Magda. And I'm going to open with a question for Jenny, and it's what helped you the most in terms of trying to, I suppose, recover, not necessarily that's the right word, but move on as best you can from what you've experienced?
Okay, well, there's several things actually. For the symptoms, a Q4 rectal washout and vaginal pessaries, they gave me back a bit of control. For mental health, through MASIC, actually finding out that there are other women like me injured in the same way and suffering. And then finding out that I could actually exercise again with the help of a routine and support shorts. Exercise really did help my mental health. I started running, and I found that like meditation, I was able to clear my head through just a repetition of running. And then getting closure, because I took legal action against the hospital, which took 6 years. Getting the apology from them when it was all over really felt like release, and that I could move on from that, and I could forgive myself. And the hospital, whilst I can't name them, they are one of the hospitals championing the care bundle, and in my eyes they have atoned for their sins by doing that. So I've taken a lot of comfort from the fact that they are doing the best they can to stop this happening to other women.
I just want to ask, based on that question, actually, how can you find out, and maybe Magda, you could answer this, is how can you find out which hospitals or centres are offering the OASI Care Bundle 1 and 2?
So the participants that participate in OASI 1, the participating maternity units, I believe you can find that in the trial registration that you can find online. I'm not totally sure if it's on the OASI Care Bundle website. But we can definitely send out links. I can prepare those and circulate them.
Okay. And Bob?
Yeah, we have a question here from Marie Herworth. I think I'd like to put this to Abdul if I could. Thanks so much for your talk. What are the stats to support rectal examination in all women, the incidence of 3rd and 4th degree tears with an intact perineum? And then Marie says, without this, I do not feel the woman is able to make an informed decision about whether or not she should have a rectal examination. And I do not think we can underestimate the distress a rectal examination causes women after birth. For example, your perineum is intact. I can't see any evidence of a tear. In rare circumstances, quantify 1 in 1,000, there's a tear in the anal sphincter despite the perineum being intact. Do you have presumably these data available? Abdul, do you want to mention about rectal examination with intact perineum and the incidence of tears in that situation?
Yes, thank you for that question. First of all, you will not get a tear of the anal sphincter with an intact perineum. The problem is ensuring that the perineum is intact, and secondly, ensuring that there isn't a buttonhole tear within the rectum. So without a rectal examination, you cannot exclude a tear of the rectum, a buttonhole tear, or a missed 3rd degree tear. For example, in this study that we did, where we followed up, where the research re-examined every woman after delivery, there was one woman who appeared to have an intact perineum because the skin appeared to be intact on the outside. And because the remit given to the research fellow was to re-examine every woman, he then found that there was what we call a bucket handle tear just behind what appeared to be an intact perineum. And that was quite a deep tear, and we could not exclude a third-degree tear. And in fact, we had to explore thereafter and show that there was a third-degree tear. So the important thing here is to do everything possible at that time to identify these injuries, because it can have very severe long-term consequences. And Jenny has highlighted how important this is to be done at that time, because otherwise, as she's pointed out, you can have very severe long-term consequences. But also, it's not just about doing a rectal examination, it's about doing it properly to make sure that we're not missing any injuries. Having said that, many women do have suppositories inserted after their delivery, so they do have a rectal examination being done to insert these suppositories. The second thing is there are some women who are having an epidural, so they will certainly not feel any discomfort during the examination. And it is, and I think Posy has just mentioned that when you did the OASI care bundle, what women felt about the importance of the rectal examination.
Posy, do you want to add further comment to that?
Yes, thank you very much. Yes, I would really just like to add and to echo Jenny's words, really. The women that we spoke to overwhelmingly said that they would much rather that they were checked and examined properly, and if they needed any repairs, that was done there and then, rather than having to wait and women having to, you know, suffer the consequences of having missed tears. So absolutely, it's all about explaining to women the reasons why examinations are being done, and the risks and benefits of having them done. Thank you.
And maybe I'd just like to ask Abdul, based on that. So if the tear is missed at the time and then a woman has to go through secondary repair, could be albeit years down the line, what are the success rates of that being able to control fecal incontinence in the long run? And I appreciate that's quite a diverse question to ask, but statistically, what are the success rates of the repair further down the line?
Yes, so that also depends on the extent of the primary injury, whether the external or internal sphincters are damaged, and how far apart the ends of the sphincters are. In some situations, it may not be able to be repaired. But overall, the success rate is about 50% in 5 years, and that drops down to 20% in 10 years. So with time, the success of a secondary repair does deteriorate.
And I think that just really highlights how important it is to capture it at the time of injury. Magda, I have a question for you based on what is the recommendations, and Posy, you might want to answer after Magda too on this one, about the use of warm compresses.
Sure. So just to preface my answer, I'm not a clinician, so my kind of domain is very much implementation research. But so what I can say on that is that the OASI care bundle isn't mutually exclusive with warm compress, and the team very much recommends that any units that are already using it, and it meaning warm compress, and any units that have kind of local protocols in place regarding the practicalities of, you know, what temperature should the water be at, what material do you use, when exactly do you start applying. So as long as all that's in place and the clinicians from those units are comfortable using that method, then they should certainly continue doing so, and the care bundle shouldn't be a barrier to that in any way. The reason it wasn't included in the care bundle originally was really just because we don't have those guidelines in place. And we wanted to make sure, or the original working group wanted to make sure that the care bundle was something that could be implemented anywhere, regardless of what resources are available to you. But the clinicians might want to speak more about warm compress.
I can see Abdul's got his hand raised. Do you want to say something, Abdul?
Yes, I just wanted to say that the evidence, although it's mentioned in Cochrane as being protective, if you look at the two groups, on the one group had warm compresses and the other group had hands-off So the ones with the warm compressors also had hands-on in that group. So if you're applying a warm compress, you are applying hands-on pressure to it. So you can't really say it's the warm compressors that reduced the injuries to the anal sphincter. That's one side of it. And Magda has highlighted the issue about there's no clear definition what the temperature of the water of the pack should be, how long it should be applied for, when should it be changed. In fact, there have also been reports of third-degree burns occurring using these hot packs on the perineum, because particularly with an epidural, the woman won't feel it, how hot it is and causing burns. So there are lots of these other factors that need to be taken into account, and we don't know how much contribution the hands-on support contributed to the reduction in the OASI rate.
Posy, have you got anything you'd like to add?
No, I think Abdul summed it up beautifully, actually. And yeah, just to say as well that the care bundle, if people's practice is to use warm compressors, then absolutely they can continue to use them. But given the other factors that Abdul has also mentioned, just to bear that in mind as well.
Bob, I think you wanted to ask something.
Yeah, there was another question from Marie in the chat. Said, I think this is probably, well, it's to all three, but to Abdul probably. Do you think we should inform women of the things that are known to increase the risk of perineal tears according to research, such as hospital birth, maternal position, supine lithotomy squatting, directed pushing, syntocinon with multiple instrumental birth? I suppose we could add to that, of course, higher risks with VBAC and water birth as well. But Abdul, what do you think we should be informing women, particularly those who are at higher risk, about these type of things that can increase the risk further?
Yeah, that's a very important question, but unfortunately we don't have the answers. If you look at all the randomized trials, apart from what I've already mentioned for third and fourth degree tears, there is no conclusive evidence. Even if you look at water births, you get mixed responses, and just recently there have been two publications from them which shows that it does not increase the risk. So I think that the problem is that there is no clear scientific evidence for one way or the other, and therefore you can only individualize what the woman wants, explains to her what is known about it. And the other point is that it depends a lot on who's doing the delivery, who is actually experienced in doing. For example, doctors will never be able to do a delivery in all fours or in left lateral position, and whereas midwives are quite skilled on that. So if you are going to adopt different positions, it does depend on the experience of the person that are going to do that particular type of delivery. But clearly with instrumental delivery, the evidence is there that it does increase your risk, but you've got to weigh this against doing a cesarean section in the second stage of labor, when you've got to decide whether you're doing an instrumental delivery or a cesarean section, and the risks for that are much higher than doing a cesarean section electively.
Abdul, somebody though who maybe has a combination of the risk factors that you talked about earlier on, say an older woman, short, maybe got a big birth weight baby, all the risk factors there, your shorter perineal body. I think the question was saying, if you have that type of individual, are you increasing the risk further by forceps, by water birth, yes or no? VBAC, for example, we know there's an 8% risk of OASI in a VBAC. So it's the counselling for these high-risk women that is important, because they're already at risk, and are we increasing the risk further by, potentially they ending up with a forceps delivery? I would be interested in your thoughts on that.
Yes, so once again, the evidence is not there in looking at combined factors. We try to do a scoring system, because if you are going to try and minimize the risk of sustaining an OASI, you need to identify these women antenatally. And the problem is we can't identify these women antenatally, or most of them, because the risk factors occur during labor, when you can't predict who's going to have an instrumental delivery. You don't know who's going to have an occipital posterior position. shoulder dystocia. So all these factors are occurring during labor, and that's why we could not predict antenatally. It's too late when you get to the second stage and you're deciding between cesarean section and instrumental delivery, because the risks get higher at that point. So we haven't been able to do that. We've been trying for so long to identify which woman would avoid an OASI based on factors, because a lot of the factors occur during labor.
Posy, sorry, thanks,
Sure.
Abdul. Posy, you've got your hand raised. What would you like to add?
Thank you. I just wanted to add to the discussion about chosen birth positions, because that was one of the misconceptions from OASI 1, that women were being, the misconception was that women were being encouraged to give birth in lithotomy, which wasn't correct at all, because we taught midwives and obstetricians, but I mean, they obviously need to do birth in lithotomy, but we taught midwives how to do manual perineal protection in all sorts of positions. As Abdul says, we're able to help women give birth in all fours, left lateral, standing, you know, any sort of position that the woman feels comfortable in. And one of those things that we really emphasized was that women need to adopt their chosen birth position. And all the women that I spoke to, all of them overwhelmingly said that they were encouraged to adopt their chosen birth position by the midwife who was looking after them.
We've had a question about OASI 1. Did not publish information about how the 60-degree episiotomy was ensured. How will OASI 2 ensure fidelity of technique? Abdul, do you want to answer that one? Or Magda?
I think Magda, sorry, Joe, I think maybe well, Magda and will obviously know a little bit more about that. This comes from Dharmesh Kapoor, who is one of our sponsors for the meeting, and hello, welcome Dharmesh, about the Episcissors. In other words, how is that angle verified during OASI 1? Magda or Posy?
I can take a stab at it. So in OASI 1, I can't speak to it too much, but I think that in both studies, in OASI 1, what we intend to do in OASI 2 is very limited to training. Many units are already using Episcissors, so that's great, and I've heard from some clinicians that it makes it a bit easier to cut at the correct angle, right? That it's quite difficult to eyeball the right angle when you're cutting. So units that do already use Episcissors, that's great. But I think how will we ensure fidelity? I think that will really just come down to training. So with the sustainability arm, our project team is going to be providing training to those clinicians who then have to kind of relay that same training to their buddy units. We've also come up with a series of resources that are now included in the OASI Care Bundle manual. That's meant to kind of supplement training with episiotomy and ensuring that clinicians are cutting at the correct angle. But yes, because it's an implementation study, so we can't kind of interfere too much, because we're trying to replicate real world kind of circumstances as much as possible, so that we can then answer the question of how can this care bundle be implemented at scale, right? So yes, so we've included more resources in the manual, and it really will come down to the training.
Thank you.
And there's another question after that one, and it said, did the researchers, again Magda Posy, explore why there was resistance to change practice? So if you want to sort of maybe answer that one.
Well, one of the reasons that there was a whole heap of reasons why there was resistance to change. So actually it's not a simple answer, if that makes sense. One of the reasons is, as I highlighted in my presentation, we were trying to, for some clinicians, it was about learning a new way to practice, because for those who had not been hands-on before, they had to learn a whole new technique. And if you think you've been driving a car for 20 years and you're suddenly taught to drive it slightly differently, it can take a bit of time to get used to it. So that was one of the reasons. So it was about, learning a whole new way of delivering care. Some clinicians said that, as again, one of the quotes that I highlighted in the presentation, they said that they understood that the evidence was there that it reduced perineal trauma, but not for their particular practice. So it was trying to really unpick what people felt about that and trying to educate midwives, obstetricians, you know, and women as well, about why the importance of the study and why we were doing it. So yeah, lots of reasons, a whole combination of things, and it's all kind of explained in the papers that we've produced.
And will it be part of midwifery training going forward? So, you know, university level on midwifery courses, that type of thing. Will this sort of become part of that learning, the risks of OASI?
Well, we hope so. I mean, that's the ultimate aim. In OASI 1, we worked with the universities who would have had midwifery students within the OASI 1 participating units. And OASI 2, they'll continue to try and foster those relationships with the universities so that that those student midwives are being exposed to that. So yes, absolutely. That would be great going forward, because education starts on day one, doesn't it, really? So we need to be able to capture the younger generation going forwards.
Thank you. Bob?
Another question here, speaking from Caroline, says, speaking about prevention, could we speak about solutions when starting the subject about tears? For example, physiotherapy, pessaries. It will make it less scary and avoid long waiting referral due to lack of knowledge of what is accessible for women. So, in other words, I mean, a really important question about physiotherapy immediately after delivery. I don't know whether, Posy, you want to take that one? You're on mute at the moment.
Sorry, sorry about that. So, well, if one of those things that we wanted to talk about was, you know, pelvic floor exercises, and in the online hub that we developed, we do talk about the importance of pelvic floor exercises early on, and having that kind of postnatal conversation with your midwife, irrespective of what sort of tears that you've had during birth, to understand if you have any urinary incontinence or fecal incontinence at all, and for those women who do, to kind of have early referral to speak to their GP or their health visitor and get that referral to the physios, because early referrals are really important, and it's not something that women should be suffering with. They should, you know, they should know that they should be able to speak up and be able to access that care that they need.
Jenny, if you don't mind me asking, was there any discussion, or were you advised to see a physiotherapist after your birth?
Not immediately. It's only when I started having problems and I saw my GP and I insisted on being referred to see a specialist. And at that point, it was about 3 months afterwards that I actually was in the system, and I was given some exercises to do, which initially didn't help, but over the years it has improved. But yeah, it's definitely early intervention, knowing what to look for, actually, because especially when it's your first birthday, if it's your first child, you don't know what's normal and what's not.
Absolutely. Well, the good news for people who are listening is that the NHS long-term plan plans to provide physiotherapy, or certainly pelvic floor exercises, under supervision for all women after delivery by 2023. That's been worked up at the moment, and that's a really fabulous advance and could prevent a lot of the consequences of OASI in the longer term. So that's good news. Jo, are there any other questions there?
I was just going to ask, based on that, what recommendations would you give to the woman who's pregnant about maintaining her own health to give her the optimum chance going through labour? So obviously some of it in terms of your health and well-being depends on what you do during your pregnancy. So what recommendations, going to things like your pelvic floor, would you advise to give you the optimum chance? So I'm thinking along the lines of like understanding how your pelvic floor works prior to having your baby, so that postnatally you're in a better position to try and engage those muscles. But is there anything else that you would add into that?
Well, there's masses of things, and going back to the perineal online hub that we have, there's, you know, other stuff about perineal massage antenatally as well. It's about women understanding their bodies a little bit more, and as you say, pelvic floor exercises, you can start doing them at any time, you know, even before you're pregnant. Just being much more aware of that, you know, your anatomy can be really, really helpful.
There's one last question again. It was really a follow-up from Dharmesh Kapoor about the answer that was given on the Episcissors and the angle. All I can say is that Abdul will bring that up at the advisory group for the OASI 2, and hopefully we'll be looking and be able to answer those questions and maybe get some idea of the angle when episiotomies are performed. So hopefully that'll answer the question. Joe, I think we're coming towards the end of our time. First of all, can I take the opportunity of thanking everybody and like to hand over to Joe to close the meeting.
So just to remind you that in order to get your CPD, we really need your evaluation form. So please fill that in at the end of the webinar. The other thing is this event is recorded, it will be edited and then be uploaded on the fantastic new MASIC website that we've now got, which is full of information on all sorts of things relating to childbirth injury, ways of managing. So please visit that. And then leading on to the next webinar, which will be on the 8th of July. And that's going to be understanding the emotional consequences of birth trauma experience. So again, a very valid webinar that needs discussion surrounding the emotional consequences of OASI injury. I'd like to thank everybody who's been here today too, and just say, please come to the next webinar and visit the amazing MASIC website. I think, Bob, you got anything else to say?
No, just to say thank you very much to our wonderful speakers. Those were 4 magnificent presentations. I'd like to thank all of you who've been listening in and the excellent questions that you put forward. To our wonderful staff at MASIC, to Anna and to Jen and to Suzanne, who've really have done so much to organise this meeting, and Sean from Events 9 or 7, who's our new conference organiser. So to them all, and to you, thank you very much, and please do join our next webinar. Bye-bye.